Postoperative pain management and assessment. The management of postoperative pain continues to be an issue for patients and health professionals. Research suggests that most patients experience acute pain after surgery, and 40% of patients have moderate to severe chronic pain after surgery, which is over 3 months in duration. In 2017, Australian hospitals performed around 2 million elective surgeries and 300,000 emergency surgeries, and these numbers have been steadily increasing each year. Frequency of emergency surgeries are 2 times the rate for Aboriginal and Torres Strait Islander people than for other Australians. The need for surgery is evident in every age group, gender, ethnicity, and socio-economic standing. Thus, the need for adequate management of postoperative pain is widely needed. High patient cohorts at risk for postoperative pain are the very young, the old, the female gender, those who have preoperative anxiety or depression, and repeat surgery patients. What is pain? Postoperative pain best fits the definition of a negative sensory and emotional occurrence due to tissue damage, often being acute, meaning the duration of pain lasts less than 3 months. Pain is also influenced by a personal, biological, social, and cultural factors. Thus, the sensation is unique for each patient. Pain has multiple negative impacts on health, including low sleep quality, immobility, mental health issues such as anxiety and depression, and lower quality of life. The poor assessment and management of pain also leads to risk of coronary ischemia, deep vein thrombosis, pulmonary embolism, pneumonia, myocardial infarction, insomnia, and poor wound healing, which may lead to delayed discharge, increased morbidity, and mortality. These secondary health issues also deplete health resources from the economy. Nurses in the post-operative setting have the role of making clinical decisions for the care of the patient, monitoring their progress, implementing nursing interventions to promote recovery, prevent pain, and to determine readiness for discharge. Effective pain management relies on nurses' use of clinical tools to accurately assess pain. Some assessment tools are the FLAC score. It is a rating system based on face, legs, activity, cry, inconsolability, mainly implemented for infants, cognitively impaired, or critically ill patients. The Wong-Baker phase is another rating tool using visual cues, which represent how a patient is feeling from 0 to 10. The most common tool nurses use is the pain scale, where a patient rates their pain from 0 to 10. These tools provide subjective data on pain experience, however, there are clinical objective data that is monitored by nurses for further accuracy of pain. Physiological signs of pain are indicated in increased heart rate, increased blood pressure and respiratory rate, or change in breathing pattern, and a decrease in oxygen saturation. The ABCDE approach helps nurses to systematically identify the physiological signs of pain and where clinical signs of deterioration can show correlations to the patient's experience of pain. Continuous monitoring of pain is required for clinical evidence of recovery and the effectiveness of treatments and interventions. Statewide approved charts including patient-controlled analgesia, ketamine infusions observation chart, and continuous opioid infusion charts are in place as protocol for the management and tracking of pain in patients. However, it is reported that 40% of nurses did not use valid assessment tools and 25% did not evaluate the effects of analgesia after administration. Management of pain. The management of pain is vital for the recovery and discharge of patients. Mismanagement of pain can leave patients with potential chronic pain which could have been avoided. Nursing-initiated interventions for pain relief are both medicinal and non-medicinal. Medicinal interventions include paracetamol, non-steroidal anti-inflammatory drugs, and the administration of ordered analgesia or opioids. Patient-controlled analgesia such as opioids through transdermal, oral, and nasal pathways are also common forms of management for pain. Non-medicinal interventions include hot or cold packs, family members present with the patient, massage, and positioning. Usage of these interventions has shown to reduce pain scores and reduce the frequency of use of opioids. Issues surrounding nursing management of pain. Nursing bias towards patients' pain experience is a common form of mismanagement for patients experiencing real pain. Studies show that nurses doubt patients' reports, often overestimating the percentage of patients who overreport their pain. Nurses need to be educated on the physiological and psychological effects of pain and how pain is a subjective experience which should be taken seriously into account. The patient's own assessment of pain should be the guiding data for pain management interventions. Thorough pain assessments must be taken, including educating the patient on why you are assessing pain and informing patients on analgesics such as opioids. Often, patients are afraid to take opioids due to the stigma attached to them, resulting in increased pain and risk of developing chronic pain. How to fix the problem. 1. Educate and train nurses. Studies prove that the main cause of mismanagement of pain is the inadequate education and training of nurses. Nurses are not always well informed on the physiological actions of analgesics and are overly cautious of the risk of opioid addiction. Educating nurses on the half-life of drugs and how to correctly determine when pain relief should be re-administered may reduce reports of underdosing in patients. Mismanagement may be reduced through educational programs and additional training sessions focused on the care and management of patients with postoperative pain. 2. Correct use of protocol. Following correct post-surgery protocol reduces the length of hospital stay in patients, thus reduces the use of hospital resources. Frequency of using standardized observation charts must be increased, based on the fact that 40% of nurses do not use validated assessment tools. In 2014, standardized charts were reviewed and had an overall improvement in safety of administration, prescription, and monitoring for patients and nurses. A study concluded that when nurses use the pain tools correctly and frequently, there is a higher response rate to deterioration, higher rates of analgesia administration, rates of cardiac and clinical deterioration significantly declined following discharge, and the length of hospital stay significantly reduced. 3. Increasing staffing in hospitals. Studies have shown that more hospital staffing there is, the lower the rates of reported mismanagement pain from patients. An increase of 2.61 hours per day for nursing staff and 1.7 hours per day for registered nurses decreased the percentage of patients reporting poor pain control by more than half. This study also reported that higher nursing staff has a significant impact of pain management, whereas greater staffing by interns and residents did not have this effect. Therefore, nursing staff should be increased to allow smaller patient-to-nurse ratios for better health outcomes for patients.